I'm Dr. Jess Wright. For those of you that don't know me, I do see a lot of familiar faces out there. Welcome to everybody. This evening's presentation is sponsored by the University of Louisville Depression Center and the American Foundation for Suicide Prevention. And we have a very large group here tonight, which we're very pleased to see. I'm sure this will be a wonderful talk. Before we introduce Dr. Miklowitz, I want to just say a few words about the UofL Depression Center. If you're not aware of what this center is or what it's doing, I'll just give you just a bit of a background on what we're up to here at the University of Louisville with our Depression Center. This is one of 21 centers around the United States. There are major universities, including Harvard and Stanford and Johns Hopkins. We're banding together to try to do something really important for mood disorders and related conditions. As you're aware, there's huge stigma. There are problems with the efficacy or the usefulness of treatments. Not enough people are getting the treatments they need. Not enough people that get the treatments are staying well once they get the treatments. We need new treatments, we need safer treatments, we need better treatments. We need to deliver them to more people. So we need to support this effort. We also need to support this at the national level as far as advocacy with government and others that might influence things like insurance and funding for research studies at the national level. So we're hard at work at this. We have an educational program every year. We reach out to the community with lectures in the community. We call this our Building Hope lecture series. This is one of those lectures. We have them throughout the year. We have an annual conference every year. It's going on right now. This is the inaugural session for it. Tomorrow, Dr. Miklowitz will be meeting with faculty, residents, and students from the University of Louisville to teach them about how to help families and to do family therapy with people that might have a bipolar patient within that family. And then on Friday, we have a professional conference, which lasts all day. Dr. Miklowitz will be speaking at that, along with a number of other people. And this is part of what we do at the University of Louisville to try to educate the public, to educate our physicians, our students, our psychologists, social workers, and nurses to do a better job of treating people that have mood disorders. We're also engaged in collaborative research on many fronts with other centers of excellence around the country, and are very excited about the possibilities of this research panning out and giving us answers for these age-old problems. So it's a real pleasure to introduce Dr. David Miklowitz. I would imagine some of you have heard of him because you may have read his book or heard about his book, The Bipolar Survival Guide. In my opinion, it's the go-to book for patients and families. It's by far the best book that helps people understand what this condition is and what we can do about it. He's also a world-renowned researcher. He was the lead researcher in the largest study ever done for bipolar disorder, the STEP bipolar disorder study, and is actively engaged in very important research at UCLA, where he's a professor. So we want to give Dr. Miklowitz a warm Kentucky and Indiana welcome. So here we are with Dr. David Miklowitz, who's going to talk to us about how to manage bipolar disorder.
Thank you very much for having me. I thought there was going to be some bourbon on the stage. But it's a pleasure. Thank you, Dr. Wright, for having me. Can everybody hear me okay? If you can't, if I start mumbling somewhere in the middle of the talk, please do something like this. Don't use your middle finger, just use your thumb, and I will try to talk a little louder. On this first slide, I just want to point out there's a website, semmelUCLA.edu/champ. The reason that's up here is because the slides I'm about to show are downloadable. You can go to the site and you'll find there's a little tab that says downloads, and you can get the slide set here. So let me just start by saying, first I always like to start off with a quote. How many of you have read Kay Jamison's excellent book, An Unquiet Mind, about her experiences with bipolar disorder? If you haven't, I highly recommend it. So that you get a sense of what it's like to have this illness. She said this about her first experience of learning that she had bipolar disorder. She said, "The endless questioning finally ended. My psychiatrist looked at me. There was no uncertainty in his voice. Manic depressive illness. I admired his bluntness. I wished him locusts on his lands and a pox upon his house. Silent, unbelievable rage. I smiled pleasantly. He smiled back. The war had just begun." The reason I put that out there is because coming to accept this disorder often as a young person, people get diagnosed at age 18, 19, 20, early 20s, sometimes even in their teens. It's a long-term process of getting used to the idea of having an illness, having to take medications for it, especially an illness that may go underground for long periods of time. 30 years of research on bipolar disorder has taught me one thing that probably most of you already knew, which is that managing bipolar disorder is more than just taking medications. Sounds like a simple proposition, but in fact we're in a society where the treatment for bipolar disorder is primarily pharmacological. We sometimes forget that there's a psychotherapy, a support group component to it, a stress management component to it, and that really getting a handle on this illness requires quite a bit of family involvement, personal involvement, self-management, strategies that go well beyond just taking pills. And I'll talk to you tonight about what some of those are. I have a list of what I call the 8 self-care principles, and I'll be going through these one by one tonight, and then of course I'll leave plenty of time for questions at the end. The self-care principles include monitoring moods, knowing one's early warning signs, recognizing, managing stress triggers, stabilizing sleep-wake rhythms, knowing one's position on medications, developing a mania prevention plan, communicating within the family, obtaining reasonable accommodations at work or school, and getting regular therapy or joining a support group such as the one we're in tonight. I'm going to go through these one by one and give you some examples of how to implement those. But first, again, bipolar disorder, as we know, is a disorder that goes from extreme lows to extreme highs. When people are manic, they are elated, grandiose, have a decreased need for sleep, really are moving a mile a minute, are losing jobs, often doing impulsive things, impulsive sexual acts, reckless driving, spending lots of money, alternating with periods of extreme depression. And in between, if the person is lucky, they may have long periods of being well. But needless to say, that really costs a lot in terms of one's day-to-day life and the life of the family. How do we get a handle on the cycling of these episodes? The first thing we recommend to any patient, client, however you want to refer, in our clinic, and we run a child and adolescent mood disorders clinic, although I've also managed adult clinics, one of the key principles is to monitor one's moods and know one's early warning signs. So be able to chart on a day-to-day basis, what's my mood like today? Am I high? Am I low? Am I feeling normal? What are the signs? What are my signs that things are getting worse? What are the so-called early warning signs of a manic or depressive episode? Family members get very good at recognizing what are early warning signs. And I've learned over the years that when a family member calls me and says, I think my son or my daughter is getting sick again, I listen, because they're usually right. And they don't say, I think my son is having decreased need for sleep and grandiosity and elated mood and irritable mood for 2 weeks. They say, he's got that look in his eyes. He is standing too close to me. He is speaking more loudly. He's waving his arms. He smells different. He's collecting things and putting them under his bed. These are the things he or she does before he gets ill. And that's the brief window of opportunity where we may be able to actually prevent a full episode from coming about. So I might start off by simply illustrating what some of the symptoms of mania are. In a session, I might hand this to a client and say, which of these have you had? Now, I work with families. So a typical patient of mine will be a bipolar person, young or old, who's there with a mom or a dad or a sibling or a spouse. And they're each describing what a manic episode looks like. Increased sexual thoughts, talking fast, racing thoughts. My mind goes very fast. My mood is at the top of the world. I have overwhelmed, overconfident, unrealistic thinking. So as an example, a patient of mine who was 19 years old called me one day, left a message on my answering machine and said, I'd like to have a meeting with the doctors who are treating me. I'd like all of you to meet together and discuss my case, and I'd like to have a lawyer there as well. On the second day, there was another message. It said, I would like not only my doctors and my lawyer to be there, but my high school gym coach, my ex-boyfriend, my high school favorite teacher in high school, and the representative from social services. Third day, it was a party, and there was a limousine coming to pick me up. Bruce Springsteen was going to be there. By the fourth day, she was in the hospital. So this was the beginning. These were the early warning signs of her manic episode, which over time her parents became more and more familiar with. Likewise, people go into symptoms or states of depression, and the thing we worry about most with the depression is it's harder to treat than the manias. The medications we have for mania are pretty good on the whole. They have side effects, but they do tend to control manic episodes. Lithium, the antipsychotic medications, lamotrigine, valproate or Depakote, all those, Abilify, these medications do a pretty good job of controlling mania, but people spend 2 to 3 times as many of the weeks of their lives in depression states as they do in mania states. And we don't have as good treatments for depression as we do for mania, which is one of the reasons we recommend psychotherapy so highly. The other problem, of course, is that antidepressants we have to use pretty judiciously because they can set off manic episodes in people who are predisposed to bipolar disorder. I'll say more about that later. What do I mean by daily monitoring of mood symptoms? Well, what I tell my clients is that this is one of the things you can do in addition to taking medications that will help you control your mood, help you get a handle on what your cycling is all about, help you get a sense of control. It'll help you link up your mood changes with stress, sleep, alcohol, certain types of events that may be triggering mood swings. This was developed by a 13-year-old girl in my clinic. We gave her a mood chart that we wanted her to fill out. This was the mood chart from the STEP bipolar program, which all I can say is it looks an awful lot like a 1040 form. It's got boxes and numbers and arrows and ratings you have to make. And she took one look at it, made a paper airplane out of it, and tossed it across the room. So we said, well, how about making up your own mood chart? And she said, well, I don't really get manic or depressed. I feel my moods go from super hyper to energized and down and then angry. So we asked her to keep track of those moods. You can see that over a relatively brief period of time, she had ups and downs. If you look at her sleep, where she wakes up at 7, goes to bed at 11, wakes up at 6, goes to bed at 10:30, her sleep-wake cycle starts to change during the weekend, not unusual, certainly for a teenager. She describes these mood states very clearly. Super hyper, I feel good about myself, I talk faster, I need less sleep. When I'm angry, I hate everyone, I'm irritable, I snap easily. Over time, when people keep these records, they start seeing the linkage between mood swings, changes in sleep, and sometimes if they're able to track their life events, they start saying, you know, every time I have a negative interaction with someone else, that's when my mood swings. Or whenever I spend too much time on Facebook, or whenever I have an argument with the boss, or I get into a new relationship, it can be a positive event. That sets off my mood swings. It's very important to be able to recognize those patterns.